exam. I'm used to seeing physical exams that clearly are one click that simply paste in a thorough physical, and it's pretty clear that it's not clear that there was any physical done at all. In this case, you can see a gait that looks real. You can see lungs clear but markedly decreased. My guess is that's because of body build rather than emphysema. He even, and it looks like one of the main focuses of this visit was his venous stasis disease of his lower extremities. Remember, this is someone who's only 55 years old. Go ahead and scroll down. You can now see his med list. Keep going, Mitra, so that Advair is at the top of the page there, just above the page break. Yeah, okay, keep that. Okay, so he's on an Advair inhaler. He's on ProAir, on bupropion, which was either for depression or smoking cessation or both, but I don't think he's a smoker. Fluticasone nasal spray, horse chestnut 300 milligram capsule, not sure what he was taking that for. Lisinopril HCTZ for his blood pressure, trazodone, actually 100 milligrams, 200 milligrams at bedtime. And some of you are probably picking up on a clinical issue that I'm not going to name, and we'll see if it comes out in the discussion. Keep going. And so that's all the clinical, but now we want to show you, Mitra's going to put up his spirometry in the format that you're familiar with. And Lisa Emery always gets on me for calling on her without warning in the middle of everything, but I apologize, but I'm going to do that again, Lisa, because you've had a chance to look at this. So I'm going to ask for you to just take us through this as you saw it.
Okay. If you go to his actual pre-bronchodilator, his ratio is 62. So that tells me, per the GOLD guidelines, that he has obstruction. And then when you go over to grade it with percent predicted, that he has moderate obstruction. The FVC indicates a mild reduction for, his restrictive component. And then when you go over to his post-bronchodilator, his ratio is 67. He has a 14% increase. Not quite sure where those actual numbers have, would have gone to.
I can help you there, and we're not gonna.
Yeah. So, he would still be moderately obstructed if I was doing the math correct, and he would still be mildly restrictive. When Correct. You go down to the lung volumes, however, there's quite a bit of total lung capacity. Looks like 142, and so that would indicate by our little help by Dr. Sela last time that he would have hyperinflated lungs and he's possibly air trapping. And when you go further down to the to his diffusion, which is not on this page.
And which we don't have, Lisa, because I just had to, this is all I could get with a screenshot. So we're not going to have
okay.
that.
But I do know he had, was it like in the 50s?
Yeah, it was mild
moderate reduction.
Yeah, it was in the high 50s, I think.
Okay, moderate reduction in diffusion.
Let's call it 50, call it 55.
Okay, we'll settle on 55. Sounds good. So I think that what would be confusing for Dr. Doyle in reading this is you have, a forced vital capacity that's screaming restrictive impairment, but then you have a true lung volume stating that there's, doesn't look restrictive. It looks hyperinflated. So I think that's the confusion. Am I correct?
Yes.
Yeah. And did you want my interpretation on possibility?
Sure.
I thought, well, I mean, as long as the numbers are right and it was a good test, and maybe we should see the flow volume loops and graphics. I thought maybe it was that, you know, you have, to me, if I wasn't looking at the restrictive component, I would say this is, you know, obstruction with emphysema, but then maybe the forced vital capacity is hinting at that asthma component of the restriction. Yeah, that's, it's a confusing PFT to interpret. So that were my thoughts.
And we could talk about it now, but I think it's fine to talk about it later along with the other cases that Dr. Sela presents.
Thank you all so much. That was a great case presentation. Totally fine with whatever the majority would like to do. We can either discuss it right now or throughout Dr. Sela's didactic. So, did anyone have any comments, questions, or thoughts about the case?
Yeah, I'm dying to know what Dr. Sela and has to say about that. Where I was on, where I was wrong, I'm okay with that.
I mean, your interpretation is correct. You know, I think part of maybe some of the restriction that we're seeing may be related to his body habitus as well, with his weight being 325 pounds. You know, when you've got a stomach that's pushing up on your lungs, when you've got large breasts that are, you know, weighing down on your chest, a pregnant belly that's pushing up on your stomach, you know, we tend to see restrictive lung disease in that case. And so that may, you know, contribute to some of that decreased FVC that you're seeing there too. But he definitely has air trapping and hyperinflation, like you said. So I don't know if the weight is contributing to that, or if there's something else going on. I don't remember seeing occupational history. So that would be something else, you know, especially with the low diffusion capacity that we'd want to know about too. If anybody else has any other thoughts.
I mean, he's got a atmospheric level residual volume on the chart. So, I mean, clearly there's a lot of air trapping. That's why I think of residual volumes, but it would be fun to see the graphs and see if it just kind of goes up and 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 up till we, you know, to 30 seconds or who knows, to, you know, to confirm that kind of a finding.
You can't diagnose, you know, physiologic restriction based on spirometry because half of apparent restriction, half of people with apparent restriction on spirometry actually have obstruction, have obstruction and pseudo restriction, like this patient does.
And that's certainly how, if I were reading these pulmonary function tests straightforward, that's what I would read, would be pseudo restriction given the enormity of the air trapping and the hyperinflation as well.
Thank you all so much. Love the thumbs up, Dr. Doyle. And Lisa, were there any other questions about the case that you wanted to maybe discuss with the group as well, or?
No, I think that I think we've kind of ruled out what the pulmonologist would have said about the pseudo restriction, plus the body weight. So I'm good with that.
I Googled the horse chestnut, and apparently it's used for venous stasis.
Great, that fits. And one other thing that, as I looked at this case, I mean, it didn't strike me except till I was halfway through writing up the case, and I would like to really encourage our RTs and our sites again to be brave and submit some cases. And, you know, you can just go to, especially those of us, well, with EHR, you can just go to the last visit and just cut and paste the history and stick it into the history, and then just cut and paste the physical and stick that in. And then you can cut and paste the med list and stick that in. And then you can upload the spirometry as a attached file. Although it's better to do a screenshot of it so you can totally de-identify it like we did here. And you're done. And so it doesn't have to be a big thing to submit a case. And Mitra and Elizabeth are always putting the link in. So please be brave and submit your cases. You're seeing them every day. And the other thing is, great thing about it is it can be just as much a mystery to you as it is to everybody else. You don't need to have the answer. You got this great group of consultants here. The other thing about this case that jumped out to me as I was going through it is it was like, my God, this guy obviously has terrible sleep apnea, which has not been diagnosed. Is unfortunately being treated with 100 milligrams of trazodone at night, which isn't working, which is no surprise. He's fatigued during the day, but he also has no health insurance. And so it's not a big mystery why he hasn't gotten a sleep study and why, even if he did get it, he wouldn't have CPAP. And that's a topic for another day. But clinically, that also is another part of the picture here. But we're about spirometry interpretation today.
Thank you so much, Dr. Doyle. And absolutely, I second everything you said about the case submissions. And anyone who has questions about it along the way, we're always here via email or phone or anything, so we can help you guys submit cases. So any other comments or questions or thoughts?
Do you know, did he get blood gases?
Dr.
I didn't see him, and he's. I'll chat his Cabin Creek record number, and you guys can look at the record in more detail, including the curves, if you want there.
Yeah, no, I'm just asking because I mean he's obese enough. He could be what I call the classic Pickwickian with the blood gas, with long-term CO2 retention. I mean, there's obesity, the obesity hypoventilation syndrome, but then you can keep going beyond that to get so bad that you can't correct during the day. And I don't know where he's at. He needs some sort of a breathing machine for overnight use probably, but we just don't know that yet. We don't know which machine.
Well, he's our patient there at Cabin Creek, so we can make that the action plan, and and he doesn't need health insurance to get a blood gas, and we can do it right there.
That part's true, but and the people here are actually pretty clever at figuring out how to get the CPAP machines off of Amazon for people who don't have insurance. They actually work pretty well and are reasonably affordable.
Thank you so much, Dr. Werns. That's great to know. Thanks for sharing that with the group. Any other thoughts about the case or anything related to the case before we move to the didactic portion?
So, Dr. Weiss, if you get the CPAP machines on Amazon, who's in charge of setting them, and who's going to prescribe this? Who's going to prescribe the settings?
So those machines, most of the one, well, yeah, Dr. Doyle's put his hand. Most of the machines that you can get on Amazon are self-adjusting.
Okay.
And the vast majority of the CPAP machines that are started in use today are self-adjusting. And so most of them, and this is plain CPAP. This is not BiPAP, and this is not Trilogy.
Mm-hmm.
It's not those machines. Those you have to still adjust. But almost all the CPAP machines now, their computer is smart enough that it can puzzle it out. Now, sometimes you have to override that, but the vast majority of people, you can do that. They've been making those for quite some time. I first ran into those, I don't know, 15 years ago in Sky Mall. What they were selling you was a CPAP machine for your house at the lake. So you didn't have to take your CPAP machine back and forth. And self-adjusting for about $600 at that point. And technology's only gotten better since then.
Right, just auto ramps to what they need. Got it. Well, that's a good suggestion.
Dr. Doyle, if you can, send me the MRN number on that patient and I'll try to see about the insurance. It could be something that there's just a lapse in they're bringing in their finances, so we can see if they qualify for a slide here or even Medicaid. So just if you'll send that to me, I'll see what we can do.
Excellent. Thank you all so much. This has been such a great discussion. If there are any further questions or thoughts about the case or anything related to it, just feel free to shoot us an email. We'll distribute it out to the group as well. And Dr. Sela, did you want me to make you co-host so you can pull up the PowerPoint on your end, or would you like me to do that? I'm totally fine with whatever you'd like.
I'll let you do it because I closed it out on my computer.
Sure, absolutely. Alrighty, so I will share my screen. Just let me know when you'd like me to advance the slides.
Okay. Oh, I hope there's not a whole bunch of transitions in here. I didn't put those in, so I apologize. But today we're going to talk about interpretation of pulmonary function tests. Next slide. So the objectives for today is to discuss the different components of pulmonary function testing and what the results of pulmonary function testing mean. And then we're going to actually interpret some pulmonary function tests. Next slide. So first, I wanted to talk just briefly about medication withholding times. This table gives an example of how long we should be holding inhalers prior to testing so that we can get a good, reliable test. I do this for my asthma patients every time, and I do this for my COPD patients at least the first time that I get spirometry. I'm not quite so strict about withholding medications on subsequent exams for COPD patients unless there's an issue. And I should say overall, I always tell my patients that I would rather them take their inhaler and let us know that they took their inhaler than end up in the emergency department because they can't breathe. So, you know, if it comes down to withholding medication or ending up in the emergency room versus having some medication on board for pulmonary function testing. But the current recommendation is that your short-acting inhalers like albuterol or levobuterol are held for about 4 to 6 hours prior to testing. Your short-acting muscarinics like Atrovent for 12 hours. Your LABAs, 24 hours, your ultra LABAs, which are the ones that are taken just once a day, I think what's on the market now is Incruz. It would also be in Anoro, it would also be in with Trilogy, would be 36 hours, and then your long-acting muscarinics would be 36 to 48 hours. So we're asking them to hold medications for at most for 2 days. The other thing that patients should know is that on the day of the test, they should not smoke for 6 hours prior to testing. They should not drink alcohol for 4 hours prior to testing. They can have normal dietary servings of caffeine and chocolate, but they should not be, you know, downing 18 cups of coffee before they come in for their breathing test. Next slide. So we always want to make sure when we're interpreting pulmonary function testing that we look for quality, and it's something that should be commented on at some point, whether it's by the respiratory therapist, you know, that this met standards, or something that's commented by the interpreter. But keep in mind that tests that are less than optimal still may contain some useful information. We do need to make sure that testing is acceptable and reproducible. Acceptable tests mean that the FVC is acceptable if there's a good effort that's made. You should have a rapid increase of airflow at the start of your exhalation. Complete exhalation requires at least 6 seconds of exhalation with a plateau in flow. Tests are reproducible if you repeat it 3 times and all 3 FEV1s must be within 200 mLs of each other, and all 3 FVCs must be within 200 mLs of each other. Next slide. We also want to reference somewhere on the report the reference equations. And these are the set of normals that are derived from normal or healthy subjects that are matched for age, race, sex, and height. And each reference value should have an upper and lower limit of normal. Next slide. For spirometry, we recommend, and we use here in the United States, an ethically appropriate NHANES 3 for patients that are ages 8 to 80, and there are separate equations that are used for pediatrics. For lung volumes, there's not been any specific set of recommendations of equations that have been recommended across the board. Many groups use the ones that are recommended by the American Thoracic Society in the 1995 ATS ERS workshop, or by the ECCS that were recommended in 1993. I haven't seen anything that's been updated to be a more recent recommendation. And then the same thing for diffusion capacity. There's no specific equations recommended, but most people use the ones from ECCS from 1993. They use Crapo or Morris. Next slide. So let's move on to talk about spirometry. So the first thing we want to look at when we're looking for spirometry is the FEV1 FVC ratio. And this is the amount of air that's exhaled in 1 second compared to the full forced vital capacity. The GOLD guidelines recommend using a hard number of 0.7. However, with this, you end up having false positives in males that are greater than 40 and in females that are greater than 50. So as you start to age, your FEV1 FVC ratio will decline. So if you use this hard, fast number of 0.7 or 70, you're going to be giving more people a diagnosis of obstructive lung disease. You'll also risk overdiagnosis of COPD in patients that are elderly, never smokers. So the other recommendation from the American Thoracic Society is to use the lower limit of normal as your cutoff. And so you'll start to see, hopefully most of you that are doing pulmonary function tests have lower limit of normal on your report. Next slide. And so this is a diagram showing FEV1 FVC. And you can see the green line is normal. This is what a normal curve should look like. For patients that have obstruction, they have a, it's the blue line, so it's a decreased FEV1. And you can see for patients with obstruction, they have a decreased FVC. And you can see that in the orange line. And so they never reach, you know, the upper dotted red line there that that we would expect with normal. And so you can really see how their lung volume, or how their spirometry is different, and how it shows up on your pulmonary function report. Next slide. So this diagram, this is actually a part of a diagram, and this is sort of what we're going to use as a flow diagram to interpret pulmonary function testing. So the first thing we're going to do is our spirometry, and you can see that you have 3 options here. If you have a low FEV1 over FVC, it's obstruction. If you have a normal ratio but a low vital capacity, we're concerned about restriction. But keep in mind, like Dr. Weissman had mentioned earlier, you can't really diagnose restriction based on just the vital capacity. And then the third option is you have a normal ratio. And then at that point, we'll talk a little bit more about what we do then. Next slide. Okay, so if we have a low ratio, low FEV1 over FVC, you then move on to look at the FEV1 to give a degree of severity. Keep in mind, though, that this degree of severity should be based on your post-bronchodilator FEV1 if you have one. We have 2 different tables here. The table on the top is the GOLD criteria. And so you can see that for GOLD stage 1 is 80 and above. GOLD stage 2 or moderate obstruction is 50 to 79. Stage 3 is 30 to 49. And then stage 4, which is considered very severe, is less than 30. Below is the ATS criteria. And you can see that these are slightly different. For ATS, mild obstruction is anything that is 70 or above, as opposed to 80 or above with the GOLD guidelines. Moderate is 60 to 69. Moderately severe, which is not a category that's included in the GOLD guidelines, is 50 to 59. Severe is 35 to 49, and very severe is less than 35. So depending on which guidelines your interpreter is using, you may come up with a different classification based on the differences that you see in these tables. But again, as much as possible, if there is a post-bronchodilator FEV1, that should be the number that you're using. If we go back to the example that Lisa gave us, both of her numbers fell within the same category, so you wouldn't see a difference. But for example, if you had a pre-bronchodilator FEV1 of 29, and then after post-bronchodilator, it jumped up to 36, you can see that that would actually put you in a different category. Although you still have obstructive lung disease and your bronchodilator response was not huge, it did actually change the classification of your obstruction. Next slide. Excuse me. If you have a normal ratio but a low vital capacity, what I was always taught to interpret that as is spirometry suggests restriction, but you can't diagnose restriction based on FVC alone. You do need to look at lung volumes for further classification. Next slide. Excuse me. And then if you have a normal FEV1 FVC, if your symptoms suggest asthma, you would want to consider a bronchoprovocation or a methacholine challenge testing for further evaluation, because you can have normal pulmonary function tests and still have asthma. So at that point, you know, if you're really strongly considering asthma, you would want to move on to additional testing. Next slide. This diagram I took from UpToDate shows you the flow volume loops for patients. A is a normal flow volume loop. I always thought it looked a little bit like a sailboat, with the boat being under the line, and then the above the line looks like a sail. So if you remember that that's really what your flow volume loop should look like, you can start to see some differences. Specifically, the one I want you to draw your attention to is E, which is sort of a scooped out or a concave picture, and this is more of what obstruction looks like. Next slide, excuse me. So let's move on to our first case. Case 1 is a 65-year-old male who undergoes pulmonary function testing as part of a routine health screening test. He had no pulmonary complaints. He's a lifelong non-smoker, had a prior history of asbestos exposure while serving in the Navy. Pulmonary function testing is as follows. And then you can see his flow volume loop there at the bottom. So in the interest of time, I'm gonna go through this. So we're looking at his FEV1 FVC, and you can see the pre-bronchodilator FEV1 FVC ratio is 80.95, the third number down in the second column. You can see 2 columns over that the lower limit of normal is 69.37. So he is above his lower limit of normal, so you would call that a normal ratio. Then if you move on and look at his FVC and his FEV1, they're normal. If you look at the post-bronchodilator FEV1 and FVC, those are also normal. So this is a normal spirometry. And you can see that the flow volume loop at the bottom is pretty normal. The black dots that are there on the diagram are his predicted values, and his flow volume loop matches up pretty closely with those. So this is a normal spirometry. Next slide. Again, FEV1 or FVC and FEV1 are 86 and 88% are predicted above the lower limit of normal. The ratio is greater than the lower limit of normal. Let's move on to the next slide, please. So after we look at spirometry, you then want to move on and look at the bronchodilators to see if there is a response. So bronchodilators help to determine the degree of airflow reversibility. What you want to do is you do your initial spirometry, then you would give 4 puffs of albuterol, And then 10 to 15 minutes later, you want to repeat your pulmonary function tests to see if there's a response. Next slide. The response that we're looking for is 12% and 0.2 liter increase in either the FEV1 or the FVC from your baseline. If your pulmonary function testing normalizes, then this is indicative of asthma. If you only see a partial improvement or don't see any improvement at all, it's more likely to be COPD, although asthma can also show no response in bronchodilators. Next slide. If your spirometry reverses to normal, you can safely rule out COPD. Excuse me. Some patients will note a subjective improvement in their breathing, but you don't see a change in their FVC or their FEV1. And this is thought to be because there's an increased airflow within their tidal volume range, but not during their deep inhalation. Also, deep inhalations are associated with airway narrowing, which may offset that measured bronchodilator response. So you'll often see interpreters put in a statement at the end that says a lack of bronchodilator response should not preclude therapeutic trial of bronchodilators. And basically what they're saying is just because they didn't respond doesn't necessarily mean that they won't have a good response to inhalers, and so it's worth considering a trial. Respiratory therapist may note that they feel better after they take them, and that may also be something that's documented in the report for the interpreter to read too. Next slide. So this is case number 2. We have a 54-year-old female who presents to her primary care provider with dyspnea and a cough. She's a non-smoker and has no relevant occupational exposures. And you can see the dotted line, which is fairly faint on this picture, is the predicted. You can see the shorter flow volume loop is her pre-bronchodilator, and then you can see the change. The taller flow volume curve is her post-bronchodilator. And so let's move to the next slide and look at the spirometry. Let me move my box here. I can't see. Okay, so the FEV1 FVC ratio this is set up just a little bit different. This is actually one of our old reports before we got our new machine. So the columns are labeled just slightly differently. And this actually does not have lower limit of normal. This was done, I think, before I started at Preston. So we're looking, in this case, we're looking at the FEV1 FVC ratio of 54. Our predicted is 87. So in this case, because I don't have a lower limit of normal, I will use the hard and fast number of 70. So 54 is less than 70, okay? So I'm concerned about obstruction. If you go to look at the pre-drug percent predicted for the FEV1, you can see that it's 64, which is decreased. In this instance, we do have a post-bronchodilator FEV1, which is 104. So again, you want to read your FEV1 and categorize your FEV1 based on your post-bronchodilator response. So in this instance, your 104 is normal. If you go over and look at the last column, you see that this patient actually had a 64% improvement in her FEV1. And if you look at the volume, the first category is 3.53, and I know that other category is hard to read, but it's 3.88. So there is over a 0.2 liter improvement in post-bronchodilator volumes. We're going to ignore the lower part because we haven't got there yet. So let's move on to the next slide. So as I discussed, the FEV1 FVC is below the lower limit of normal. Remember, it was 64, I think, 54, I can't remember, but it was, yeah, it was low. FEV1 was 64% predicted. This would give this patient a gold stage 2 or a moderate obstruction if you just read it based on the pre-bronchodilator spirometry. But we saw this bronchodilator response. They had a 64% improvement, a 1.43 liter improvement in FEV1, and your bronchodilator reverses to normal. So in this patient, we were able to rule out COPD. This patient does have asthma. Again, the FEV1 should be diagnosed based on your post bronchodilator FEV1. So this patient does have asthma. This patient actually responds very, very well to bronchodilators, both on pulmonary function testing and in real life. Next slide. So that's spirometry. So, the take-home points are, you want to look at your lower limit of normal so that we're not over or under diagnosing people. You want to look at your post-bronchodilator FEV1 in order to stage your obstruction. And your FVC cannot adequately diagnose restriction. Now, that being said, I'm going to show you a table if you don't have lung volumes where you can, suppose what the restriction level is, but lung volumes are really recommended. So let's move on and talk about lung volumes. Oh, sorry, last slide. Nope. Sorry. Okay, so lung volumes are important when spirometry shows a decreased FVC. Body plethysmography is the gold standard, but you can also perform helium dilution, nitrogen washout, and then measurements based on chest imaging. Interestingly, a high-resolution CT scan correlates to within 15% of body plethysmography if the patient takes a maximal inspiration. Now, while this is interesting and useful information, I'm going to say that if your PFT lab can't do a body plethysmography, it's probably unlikely that you're going to have a high resolution CT scan at your hospital or at your facility. So, but anyways, that's neither here nor there for this discussion. Helium dilution and nitrogen washout may underestimate your lung volume in patients with moderate to severe COPD because they do not access under or non-ventilated areas of lung tissue. So keep that in mind, that your lung volumes may be underestimated. So if you're doing helium dilution or nitrogen washout, you may not see as great a level of air trapping or hyperinflation. Next slide. And this diagram is a reminder of your common lung volumes. So the vital capacity, remember, that is the maximum volume that's exhaled after a maximum inspiration. It can be slow or fast, or slow or forced. Forced is FVC and slow is your SVC. Your functional residual capacity, or your FRC, is the volume of air that's remaining in the chest at the end of a tidal volume breath. So what is a tidal volume breath? That is a normal everyday in and out breath that you're taking. It's not a maximal inhale, it's not a maximal exhale, it's just your normal breath. And so what's left behind in your lungs is your FRC. Your residual volume is the amount of air or the volume of air that's remaining after a maximal exhalation. So you take a big breath in, you blow out as quickly as you can, and then what's left behind after that is your residual volume. And that's one of the things that we measure. That's what gives us the air trapping. And so you can see based on this diagram, on the very far left is your residual volume. And so with air trapping, that volume increases. Your expiratory reserve volume, or your ERV, is the volume of air that's exhaled from end tidal volume, which is your FRC, to a point of maximal exhalation. So whatever you exhale normally is your, at the end of your exhalation. If you were to take a big breath in and then exhale everything you can, the difference between what you normally exhale and what you can exhale if you're getting a full exhalation is your ERV. Inspiratory capacity is the maximum inspiration from end tidal volume to total lung capacity. So when you're at that maximal I'm sorry, so when you're at the bottom of your normal breathing and then you take as big a breath as you can, that total volume is your inspiratory capacity. It's the maximum amount that you can inhale. And then lastly, the total lung capacity is the volume of air in the lungs at the end of your maximal inspiration. And so that is the largest arrow. So it's all of the air that's in your lung. The volume that does not participate in your normal breathing, and then everything that you can inhale beyond that to your maximum is your total lung capacity. Exactly what it sounds like, total lung capacity, the maximum amount that you can have in. And so the two lung volumes that we really pay attention to when we're interpreting pulmonary function testing is this total lung capacity, and then also the residual volume, how much is left over after you exhale completely. So take some time to look at this diagram. I think it's really helpful, especially when you're trying to interpret these things, so you can sort of see the relationship between how these volumes work together. And it helps you to really sort of understand why you're seeing what you're seeing and what it means for the patient. Next slide. So again, we mentioned earlier that you cannot diagnose restriction based on FVC alone. But if you don't have lung volumes and you're trying to classify a restriction, this table was given and up to date. It's not something that I do on a regular basis, just because most of the patients that come through our PFT lab do have lung volumes, but this table does give you a suggestion for restriction. And so if your FVC is below 80% of predicted, if it's 60 to 80, they consider that mild, 50 to 60 is moderate, and below 50 is considered severe. Again, like Dr. Weissman had mentioned, oftentimes in patients that have restriction on their spirometry, their lung volumes are normal, or super normal, like we saw in Dr. Doyle's case presentation this morning. And so those patients would be considered to have pseudo restriction because their FVC looks like restriction, but their lung volumes are actually normal. And so the last bullet point here, reduced vital capacity alone is not enough to diagnose restriction, as it can be caused by air trapping due to severe obstruction. So I would urge you, if at all possible, to get lung volumes on these patients before diagnosing restriction. Next slide. Now, I mentioned earlier that there's not a standard equation used for lung volumes. There's also no standard interpretation used for lung volumes. What I used when we were in fellowship is that for total lung capacity, 80 to 120 was normal. Anything above 120 was considered hyperinflation. Anything below 80 was considered restriction. And so what we used at WVU and fellowship was the table at the very bottom, was that 60-80 was considered mild restriction, 40 to 60 was considered moderate, and then less than 40 was considered severe restriction. I also saw these other tables. The one on the top right used 65 to 80 as mild, 50 to 65 as moderate, and then less than 50 as severe. And then the table on the top left, they used a normal value of 80 to 120 for your total lung capacity. And then they used 70 to 80 for mild restriction, 60 to 70 for moderate, and less than 60 for severe. So three different tables. One of them uses less than 60, one of them uses less than 50, and one of them uses less than 40. And so it's very difficult to get any sort of standard across the board. Now that table also uses 120 to 130 for mild hyperinflation, 130 to 150 for moderate, and then greater than 150 for severe. I just generally categorize anything that's greater than 120 as hyperinflation. I don't usually give it a stage. The last row of this, this table looks at residual volume. And in this table, they consider 65 to 135 as normal. And then anything that's lower than 65, they consider restrictive. And anything that's above 135, they consider obstructive, and they give it a severity as well. Residual volume, we always use the normal of 80 to 140, and anything above 140 was considered air trapping. And I think in the first case that Dr. Doyle presented, that patient had 313. So regardless of whether you stage it or not, that was a pretty large amount of air trapping for that particular patient. So again, lung volumes are not overly clear as far as a severity, but anything that's low is considered restriction of some form, and anything that's high is considered either hyperinflation or air trapping, depending on which number you're using. Next slide. Excuse me. So again, air trapping is indicated when your residual volume or functional residual capacity is greater than 120. And the picture here shows some air trapping. You can see these sort of black areas in the lung that shows some darker air trapped areas here. And then the total lung capacity, again, normal 80 to 120. If you're less than 80, it's going to be some degree of restriction. If it's greater than 120, it indicates hyperinflation. Next slide. Excuse me, I'm sorry. This X-ray shows hyperinflation. I think we've talked about this before in this group, that the signs of hyperinflation on chest imaging include a flattened diaphragm, which you can see in the image on the left. You can see increased airspace between the ribs. And then you can also see some substernal air, which you can see on the image on the right, that there's a collection of air behind the sternum before you get to the heart. And that, you often see these patients being considered pink puffers, where they've got this inflated chest. Next slide.
Dr. Sela, I just wanted to let you know we have about 4 minutes left, and I think Dr. Doyle had posed some great questions in the chat. I wasn't sure if you wanted to go through some of those questions or what you were thinking about that.
I haven't had a chance to read the questions. I can, or we can, let's see what the next slide is.
I'd say finish the presentation and we can save the questions for another day.
Okay.
Sounds good.
Next slide. So this is a complete view of the diagram that we've been discussing. And you can see if we take the column on the left, these are patients that have a low FEV1 FVC, which is indicative of obstruction. You look at their bronchodilator. If they normalize, you can call them asthma. If they don't, we're looking at possibly asthma or COPD. We then move on and we look at the diffusion capacity for these patients, which helps us further break down what their disease may be. In the middle, we've got patients with normal spirometry. If their symptoms suggest asthma, we want to consider bronchoprovocation challenge. If they do respond to the bronchoprovocation challenge, asthma is more likely. If they do not respond, we're going to say that this patient probably does not have asthma. We do those at Preston. Also, if you have a normal spirometry and you look at your diffusion capacity, it can help you to determine whether these patients may have some early interstitial disease and pulmonary vascular disease if they have just an isolated diffusion capacity. And then on the far right, we have patients with a normal ratio but a low vital capacity. We're concerned about restriction. We want to confirm that with lung volumes. If lung volumes confirm, then we move on to look at diffusion capacity. If these patients have a low diffusion capacity, we're concerned about interstitial lung disease. If they have a normal diffusion capacity, then we're worried about either a chest wall issue or a neuromuscular issue. Next slide. So case 3. We have a 60-year-old man that presents to his primary care provider with complaints of increasing dyspnea on exertion. He has a 40-pack year history of smoking and is retired following a career as a building contractor. Pulmonary function testing is as follows, and flow volume loop is also shown here. This patient has a FEV1 FVC of 49.78. We're looking at the first column. The lower limit of normal for this patient is 70.25. So he is below the lower limit of normal. His percent predicted FEV1 there is 39% predicted. Post bronchodilator FEV1 is 53% predicted. And so you can see, again, as long as we have the post bronchodilator FEV1, we want to use that. So we're looking at a decrease ratio with an FEV1 of 53% predicted. This patient did have a bronchodilator response. He had a 35% improvement in his FEV1, 28% improvement in his FVC. He also met the criteria. Remember, you have to meet both criteria, a 12% or more improvement, as well as a 0.2 liter improvement. And he went from 1.4 up to 1.9. So he had a half a liter improvement in his FEV1. So we've got an obstructive picture. If you move down and you look at your total lung capacity, it's 117, which is less than 120, but more than 80. So it is normal. So we don't see any hyperinflation. However, his residual volume is 280% predicted. So he does have some air trapping. If you look at the flow volume loop, again, the dots are the predicted, and you can see that he does not fall anywhere within that predicted. You can see the smaller of the two flow volume loops is his pre-bronchodilator FEV1. After we give him the albuterol, you can see that he does have a significant improvement. His flow volume loop is very consistent with COPD. You do see this sort of long, drawn out breath. And so you can see that the curve sort of extends out pretty far. And this is very classic of a COPD flow volume loop. Next slide.
Dr. Sela, so we are at the top of the hour here. I think there's about 13 slides or so left. So I wasn't sure if maybe we could reschedule for like a part 2 maybe coming up here. I'll still certainly attach the PowerPoint in the recap email as well.
Sure.
And I just wanted to read out, Dr. Jewell had chatted in saying this presentation should go in the ECHO CLD Hall of Fame. Everyone will be using it as their gold standard moving forward. It's been super clear and super helpful. So thank you so much as always, Dr. Sela. It's a wonderful presentation. We certainly have to reschedule for finishing it as well. So thank you so much. The only announcement that I have is that our next session will be on June 7th, and we will be having a guest speaker, Dr. Moorhead, discussing updated NAEPP asthma guidelines. So keep an eye out for that, and we'll see you all next time. Thank you guys so much.
Thank you.
Thank you.